Let's begin with our topic of emergency medicine, and our today's topic is very important, how we can treat the patient with burns in emergency. First, let's go over the degree of burns, and we have 3 degrees of burns. First degree, then we have second degree and third degree. So 3 degrees of burn are present. Sometimes in some cases we also label the burn as fourth degree, but usually the 3 degrees of burn are common and important. The skin has 3 layers. We have epidermis, then the dermis is the second layer, and then we have the subcutaneous, which is the fatty layer of the skin. So if you see on top, that's the epidermis, from where we have the hairs coming out. So epidermis, then we have the dermis, which is the middle layer of the skin, and the third layer of the skin, if you see, is yellowish. That's because of the fat, and it's the subcutaneous layer of the skin. So in the first degree burn, only the top portion is affected, so it's called the first degree burn, and it involves the epidermal layer of the skin. In the second degree, both the epidermis, which is the first layer of the skin, and the dermis is involved. And then in the third degree burn, if you see, all 3 layers, epidermis, dermis, and the subcutaneous layer of the skin is affected. So epidermis, dermis, and subcutaneous, these are the 3 layers of the skin, and the degree of burn depends on the involvement of the layers of the skin. If it's just the top layer, we have first degree burn, then second degree burn, and the third degree burn. And as the burn becomes deep and deep, depending on whether it's full thickness, partial thickness burn, the severity of the burn becomes really bad, and it can be fatal, especially in the deep burns, when the infection can very easily reach to the bloodstream, and it can cause septicemia. Saw few very serious patients of the burn while working in the medical unit. So I kind of have a, we can say that, scare of the burn. So it's very important that we should handle the fire in the houses very carefully, so we can avoid these burn injuries, which can be really very bad and serious depending on the depth of the burn wound. So first degree burn, then we have second degree burn, and the third degree burn, epidermis, dermis, and the subcutaneous. So the degree of burns, now we know, is according to the involvement of the 3 layers of the skin. Next, also important, thickness of the burn, how thick it is. Partial thickness burn, and then we have full thickness burns are present. So thickness of the burn is also important. Partial thickness are the burns which are second degree burns, so they involve the dermis and the epidermis. So it's the partial thickness burns, second degree burns. And this is the epidermis, which is the top layer of the skin, epidermis. And that's the dermis. So we have epidermis, dermis, and subcutaneous layers. So these are the 3 layers of the skin. Partial thickness is the second degree. Partial thickness is second degree burn. So second degree burn, we already know, it's the involvement of the epidermis and the dermis. It's not involving all layers of the skin, and it's not going deep. So it's the partial thickness burn, which is the second degree burn. Then full thickness burn is the third degree burn. So if you see in this diagram also involvement of the epidermis, then we have the dermis, and then there is involvement of the subcutaneous layer of the skin also. So these are the three layers, and all these three layers are affected, and this is known as the full thickness burn. So first degree burn, second degree burn, and third degree burn. Then we have partial thickness burn and the full thickness burns. This is the epidermis, dermis, and the subcutaneous. And if you see, all the three layers are affected. In this case, you can see only the top epidermis layer and the dermis is affected. You can see the redness, erythema. In the dermal burns, we can also have the blisters, and once these blisters rupture, then we have fluid oozing out, turning into pinkish discoloration. All these pictures, we will see them later on. So first degree burn, second degree, third, then we have partial thickness and full thickness burn. Next, second degree burn, if you see the appearance, that's how the second degree burn looks like. We have epidermis, dermis involvement, and that's the second degree. Blisters are formed, and then once the blisters, they break down and fluid oozes out. That's the very typical picture of the second degree burn with the redness and the blisters. So that's the second degree burn. This is the third degree burn. You can see more blackish, brownish discoloration, and then we have deep, more serious or more severe presentation of the burn. That's the third degree burn. Next is the superficial partial thickness skull burn of the arm. You can see the burn of the arm, and it's superficial partial thickness. Partial thickness, we know it's the second degree burn, so it involves the epidermis and the dermis layer of the skin, and that's the picture of the superficial partial thickness burn. Then another is the superficial partial thickness skull burn of the chest. You can see the burn of the chest. Deep partial thickness burn. So this is the deep partial thickness burn. Superficial partial thickness on the top, just you can see this is more deep partial thickness burn. Then full thickness flame burn. That's the picture showing full thickness flame burn. And full thickness flame burn of the leg. Here you can see there is brownish discoloration as scar formation, and these features occur in the full thickness burn when all the layers of the skin are affected. And sometimes the burn can reach and it affects the underlying muscle and reaches to the bone also. So we have first degree burn, second degree burn, third degree burn, then we have partial thickness, and then full thickness burn. And in further sub-classification, we have superficial, partial, superficial, full, deep, partial, deep, full. All these are different classification of the burn in patients. Then the red flags regarding the burn patient history and concerning diagnosis. First, we have if there is explosion. If there is explosion, that's a red flag, and it can be barotrauma associated trauma. So explosion can lead to the burn. Burns in confined space. If it's a confined space, not an open space, the consequences of burn are different as compared to the open space where there is a place for the person to escape. So if there is a burn in confined space, usually it can lead to inhalation injury because there is inhalation of the smoke, and it can also cause inhalation injury. Then coughing, wheezing, and dyspnea is also a characteristic of inhalation injury. So red flags, if there is explosion, then we have barrel trauma or other associated trauma. If there is a burn in confined space, usually there is inhalation injury, and patient with inhalation injury will also have cough, wheezing, and dyspnea because of the damage to the structures, respiratory organs as a result of inhalation injury. Next, some other red flags in the history. We have the if there is difficulty speaking and difficulty in swallowing, and there is drooling or drool, it's very, very clear indication that the patient might have the upper airway burns. Upper airway burns can cause the difficulty in speaking, swallowing, and there is drooling, and also inhalation injury is the reason. So both are very, very important. If the patient have history of difficulty in speaking, swallowing, and drooling. Then pre-existing medical conditions is also an important factor. If the patient has pre-existing medical condition and they have burn wounds and they have deep wounds, and that can cause patients like diabetes. If somebody has diabetes, first thing is their wound will be very hard to treat and to heal, and then they have other consequences like as a result of burn they can go into the renal failure and they have other complications. Similarly, patient with the heart problems, congestive heart failure. So all these pre-existing medical conditions play an important role in the outcome of the burn patient. So this can increase the mortality and morbidity as if there is a history of pre-existing medical condition. Next, if there is dizziness, history of loss of consciousness, there is headache. All these are important points to show that the patient might have carbon monoxide toxicity, and all these can carbon monoxide toxicity can lead to all different manifestations like there's dizziness, headache, loss of consciousness. Then examination, finding, and diagnosis of the patient with the burn. We have the tachypnea. Tachypnea is fast breathing, and especially after the inhalation injuries, when there is injury to the respiratory tract, usually the patient have tachypnea, or they try to breathe fast to overcome that deficiency and to take in the oxygen. So tachypnea is present on examination, and this is airway burn. Then hypotension, low blood pressure. Hypotension is volume depletion. Painful burns, erythema, All these can be due to superficial burn. So again, on examination, if there is tachypnea, that is due to the airway burn, a burn of the upper airways that can cause tachypnea. Hypotension, depletion of fluid loss is also common in patient with the burn. So they have hypotension, low blood pressure. They can go into shock. If they are, there is redness and there is pain, that is usually superficial burn. There is a misconception that the third degree burns are usually more painful, but that's not true. Third degree burns can even cause damage to the nerves, and there are no sensations at all. So the superficial burns are usually more painful burns. Then again, some other examination finding here, you can see that's the patient with the burn of the hand, painful pink moist burns with the blisters. Blisters are usually present in the second degree burn when there is involvement of the dermis. So it's painful pink moist burns with the blister. Superficial partial thickness burns. White mottled pink burns, impaired sensation. Now sensation is impaired, that's deep partial thickness burn. And then if we have white charred burns with impaired sensation, that is full thickness burn. So we have different patients. First we have if there is pink moist burn with blisters. When the blisters break, these burns become moist. So if they are moist with blisters, that's superficial partial thickness burn. White mottled pink burn, impaired sensation, deep partial thickness burn, and if there is charred burns, they are full thickness burns. If there is burns to face, neck, upper torso, nasal vibrissae, carbon deposits in the oropharynx, you can see, and there is carbonaceous sputum and singed eyebrows which are burned. It is usually due to airway burns or inhalation injuries. All these are in common in the airway or inhalation injury. If there is burn to face, upper torso and the neck, most likely the patient have airway burns also, and they will have all these different manifestations. If there is involvement of nasal vibrissae, might be upper airway or inhalation injury. Carbon deposits in the oropharynx, carbonaceous sputum that comes out, and singed eyebrows. So these are characteristics of the inhalation or airway burn injury. History. What important questions we need to ask? When did the burn occur? When did the burn occur is very, very important question we should ask the patient. Circumstances surrounding the burn injury, whether it was an explosion, whether it was from stove during cooking, whether it was the explosion from the some stove. So all these are important questions to ask. Any associated traumatic injuries? Is the burn painful? Again, very important. Usually the second degree burns are painful. So is the burn painful, first and second? Suspicious settings surrounding injury. So that's also an important question. Burn pattern consistent with explanation. Lot of domestic violence cases can be lead to burn injuries. So in these circumstances, it's very important that we should find out whether the explanation given by the patient is consistent with the examination findings. So again, in the ward, sometimes you see, especially the female burn patients who have a history of burn as a result of some relatives or in-laws or due to some domestic violence. So in these cases, we need to be very careful whether there is a correspondence between the findings. Then any history of an explosion. So these are some important questions we should ask the patient with the burn. Confined in burning environment. Now, the associated symptoms of the burn, heent symptoms in the head, eye, ear, nose, throat. So there is difficulty speaking, especially we mentioned it's very common in the inhalation injury or upper airway injury if there is difficulty in speaking or there is dysphonia. Any voice change is also common. Difficulty in swallowing if there is involvement of the upper airway also. Airway compromise, any foreign bodies, and edema and abrasion. So these are some symptoms, associated symptoms: voice changes, difficulty speaking, difficulty swallowing, airway compromise, foreign bodies, edema and abrasions. Next, some associated symptoms in the lungs as a result of usually inhalation injury. We have symptoms of the lungs. Coughing is very, very common. Wheezing, trouble breathing, and also there is lungs inhalation injury if we examine the lungs. So coughing is common, wheezing, trouble breathing, and lung inhalation injury. Some neurologic associated symptoms we already mentioned also, especially in the carbon monoxide toxicity, we have some neurologic findings or associated symptoms. Headache, dizziness, loss of consciousness, and carbon monoxide toxicity. Some past medical conditions which are associated with high mortality rate. We have HIV AIDS, again it's an associated condition associated with high mortality rate if there is HIV AIDS, and the main reason in this is the immune system. Patients' immune system is weak, they are not strong enough. The infections, different infections, especially in patients with the full thickness, deep burn patient, when the trauma or the injury can reach to the muscles or the bone, any infection can very easily spread to the bloodstream and it can spread to the different parts of the body. And if the patient doesn't have strong immune system to fight against different infections, can become more serious and fatal. So any history of HIV AIDS is important, and the daily deep thickness burn can reach to the bloodstream and it can cause septicemia. Usually these patients need very aggressive management with cleaning, daily cleaning in the operation theater. The wounds should be properly managed and cleaned, otherwise it can cause septicemia. So HIV AIDS is one condition. Any renal disease, involvement of the kidney, again there will be volume depletion, there is hypotension, dehydration, and if patient already have renal impairment, it can be really, really fatal. Liver disease is another important condition, and then we have any metastatic cancer or which is present, and these all conditions can be associated with high mortality rate in patients with burn. Some other conditions with high mortality, again, if there is congestive heart failure, I mentioned congestive heart failure, the heart ability to pump is not good enough, there is failure, and if there is hypotension, volume depletion, more pressure on the heart, and it can aggravate the condition. Any pulmonary disorder, if it is present, it can aggravate the condition. Then we have some alcohol abuse. Patients who are alcoholic and they have the habit of alcohol abuse, they have high mortality rate. Then we have obesity and peripheral vascular disease. Both can be very, very bad, and they are associated with high mortality rate, peripheral vascular disease and obesity. In obese people also, it's hard to even manage the wound, and it takes long for the healing of the wound also. Then any dysrhythmias, any abnormalities in the rhythm of the heart can also be associated with high mortality rate. And then the condition is malignancies. So all these are the conditions, past medical history that can be associated with high mortality rate. Next, physical examination of the patient, vital signs, what will be the effect on the vital signs, hyperdynamic state associated with tachycardia. So there is tachycardia, fast heartbeat. Tachypnea and hypotension, we already mentioned, there is fast breathing, low blood pressure, and there is tachycardia. The pulse rate is increased, the heart rate is increased, there is decreased blood pressure, and there is tachypnea. Primary and secondary surveys, immediate life threats should be addressed. So it's important that immediate life threats, life-threatening conditions should be managed first, like ABCs. We should give first airway, breathing, circulation. If there is any problem, airway should be managed, breathing should be managed, and circulation should be managed. If the patient is in very, very poor condition, hypotension, shock, IV fluids should be given, the foot end should be elevated. Then if there is difficulty in breathing, the airway is closed, we should do the emergency airway opening and tracheostomy. So first, life-threatening conditions should be managed first. Clinical findings associated with inhalation injuries, like we have difficulty talking, speaking, difficulty in speaking, and there is also difficulty in swallowing. All these can be findings in the inhalation injury. Then determining of burn depth and total body surface area is important. In the burn, total body surface area is measured, and then treatment is given accordingly. If it's a big body surface area involved, then usually the mortality rate is high, and usually the recovery is very, very poor. So it's very important to measure the total body surface area in the burn patient. Next, bedside assessment of the depth of the burn. So how the superficial burn will present. There will be brisk bleeding on pinprick testing. So superficial burn, if we touch the pin to the patient, in superficial burn, the brisk bleeding will occur on the prick testing because the blood vessels are intact, and this is superficial burn in which the epidermis is affected. Light red, dry appearance, painful sensation. So all these are very, very important in the assessment of the superficial burn. Then there is also brisk blanching to pressure, change in the color on pressure that comes back to the normal after the pressure is released. Superficial partial thickness burn, how we assess that? Brisk bleeding on again pinprick test, painful sensation, slow return, capillary refill, and moist and pink appearance. Now these are the moist, they have blisters present, and there is pink appearance of these superficial partial thickness burns. Then deep partial thickness burn, delayed bleeding on pinprick test. Now it's deep, there is delayed bleeding on pinprick test. Dull sensation, not the painful sensation, there is dull sensation, mottled pink red, waxy white look. And there is no capillary refill. So few important differences between the superficial and then we have deep, delayed bleeding on pinprick, dull sensation instead of painful sensation, and there is no capillary refill. Then full thickness burn, there is no bleeding on pinprick test, no sensation and capillary refill, white, charred, dry appearance. The charred appearance is very characteristic of deep full thickness burn, and there is no sensation, no capillary reflex, no capillary refill, and there is no bleeding on pinprick test. Now, rule of 9, very, very important common rule of, the rule of 9 is used for the estimation of the body surface area, burn surface area of the patient, how much area is burned, and that's very important as far as the management is concerned. So, rule of 9s. In the rule of 9, the head and neck is the 9%. So if the head and neck is burned and all the other part of the body is not affected, it means it's the 9% of the body surface area is affected. So head and neck is 9%. Trunk, front is 18% and back is 18%. So front and back both is 18%. Arm, each arm is 9%. 9% right arm, 9% left arm. Actually, if we talk the front, 9% is the chest and then the front abdomen 9. So it's basically the rule of 9. Then genital area is only 1%. Leg again 18% each. So that's the rule of 9. And we measured the body surface area affected by the burn, and this is known as the rule of 9s. Another method is known as Burkow or Lund-Browder burn size chart. And that's the chart that is important, the front and the back. The A is the half of the head. Then we have 1 and 2. This is 1.5, 1.5, 1, and then again 2. That's the distribution in the Burkow burn size chart. 1, 3 by 4, 3 by 4. B is half of the upper leg, and C is the half of the lower leg. That's the distribution in the front portion, and that's in the back. Then determination of the depth of the burn. Rule of palms for size of small burns. Inaccurate assessment usually impacts circulation. Size overestimation, hospital transfer. Now, some differential diagnosis of the burn condition. We have pemphigus vulgaris. Pemphigus vulgaris, you can see, is the infection that caused the lesion on the skin with erythema and some yellowish discoloration. You can see that's the pemphigus vulgaris. Histopathology or direct immunofluorescence test is performed for the distinguishing between the burn and the pemphigus vulgaris. Then we have, this is the picture of staphylococcal skin scalded syndrome. This is the infection caused by staphylococcus, and this is staphylococcus scalded skin syndrome. And its diagnosis is confirmed by culture and biopsy, and that gives the growth of the staphylococcus. So another condition in the differential diagnosis is the Steven-Johnson syndrome, and this is again confirmed by the biopsy, and it can occur as a result of some drug reactions or drug allergies also. And the last condition which is in the differential diagnosis here is the TAN, and it's the toxic epidermal necrolysis, and you can see the epidermal necrolysis or the death or scaling of the skin is present, and this is again diagnosed by the biopsy. So these are some conditions which comes in the differential diagnosis of the burn patient. Some diagnostic tests or the lab studies which can be done. We have the arterial blood gas analysis, very, very important, especially after the inhalation injuries or the injuries of the upper airway when the breathing is affected, arterial blood gas analysis. Serum ethanol and urine toxicity or toxicology is done also for alcohol abuse. Types and blood screening, again important in case of transfusion. Hepatic function, calcium, phosphorus, magnesium, all these are the different lab tests that can be performed. Some other tests are the radiologic studies, x-rays can be done, electrocardiogram, and then the laryngoscopy. Very, very important in case of inhalation injuries. Then the ECGs can be performed, electrocardiogram if there is any arrhythmias or dysrhythmias, and then laryngoscopy, especially if there is involvement of the, in case of the neck and the face, and how if we to look for the involvement of the upper airway, we should do the laryngoscopy. Then some treatment principles for the burn patients. The general treatment principles, very important, is pre-hospital care. Before reaching the hospital, if the burn is massive or if there is inhalation injury, if the patient has loss of consciousness, different factors depending on how bad is the situation, pre-hospital care is important. And then emergency department care. And fluid resuscitation is important if there is hypotension, and if there is hypovolemia, then fluid resuscitation. The treatment of inhalation injury, initial fluid resuscitation, then endotracheal intubation, and high flow humidified oxygen is given. Carbon monoxide toxicity, pulse oximetry to find out the level of oxygen in the blood. Carbon monoxide oximeter again to find out the level of carbon monoxide. HBO therapy, hyperbaric oxygen therapy is given. Then some other options for the management of the burn patient. We have the sclerotomy, scars which are formed as a result of the burn, especially the deep, full, thick neck burns, leads to the scar formation. Sclerotomy is very important to relieve the pressure and to clean the wound is important too, because then the wound that will be healed will have lot of scarring. So sclerotomy is very, very important. Usually these patients are transferred to the operation theater in the beginning, maybe twice or 3 times a day to do the sclerotomy to clean the wound, and then they can be again managed and covered. Antibiotics are also very effective for the prevention of any infection. Bladder catheterization, nasogastric tube, and analgesia. These are all very important treatment options, should be performed. Sclerotomy, antibiotics, bladder catheterization if patient is not able to walk or go to the restrooms, nasogastric tubes if they are not able to swallow or eat, and then analgesia for the pain is important. These burn, again, as I mentioned, depending on the severity and the depth of the body surface area that is affected by the burn, the management will be different. Sometimes just the superficial burn with the putting in the cold water for some minutes is good enough, and it can relieve the redness and the pain. But otherwise, deep burns should be managed aggressively to prevent any infections or complications that can be associated with those burn injuries. Then outpatient care of the burn, depending on the severity. If it's the minor burn, very important, less than 10% of the body surface area is involved. That's in adults. Less than 5% in young or old. Less than 2% full thickness burn, and these are the minor burns, and they can be managed as an outpatient, and they do not require any hospitalization. Then moderate burn. Which are the moderate burn? 10 to 20% body surface area is involved in adults. 5 to 10% in young or old hospital admission. 2 to 5% full thickness burn, high voltage injury, and suspected inhalation injury, circumferential burns. All these are the examples of the moderate burn. Then the major burn. Major burns are the burns if they have more than 20% of the body surface area in adults and more than 10% in the old and young age group. More than 5% full thickness burn, high voltage burn, and non-inhalation injury, referral to burn center disposition, and associated burns or injury. So all these are the major burn examples. Silverdene covered gauze. That's the silverdene covered gauze that is used for the burn patient. Then some special burns. Example of some special burns is the burn caused by the tar. That's the tar burn. Tar is produced by burning the coal. So that's the tar burn. Then we have chemical burns. Sodium hydroxide, that's the appearance of the person with the chemical burn, and the chemical was sodium hydroxide. Again, the acetic acid burn, that's the acetic acid burn. 98% sulfuric acid, H2SO4 burn. Electric burn, how the patient will electric burn. Usually the electric burn patient have the point of entry and exit for the electricity. So these are the electrical burns. The disposition of the patient, we have how we dispose the adequate home environment for care. So disposition for outpatient care is important, that the patient should have a proper home environment and they have somebody to take care of them at home. So it's very important, we should ask if they have adequate home care available or not. Can patient care for burn at home? Psychosocial factors reducing care optness. Is patient able to follow up as instructed? So these are very important steps in the disposition of the patient as far as outpatient care is involved. Finances, any friend who can assist in care. Some pearls, pitfalls, and the myths. Direct thermal injury affect upper airway. That's one pitfall and myths. Direct thermal injury affect upper airway. Headache, dizziness suggest carbon monoxide toxicity, not always so. Lactated Ringer's solution commonly used, and Parkland formula, IV fluid administration. Again, these are some pearls and pitfalls and the myths as far as burn wound is associated. Some other IV fluid resuscitation wound care principles. Young children require greater fluid. Silverdene used with closed burn dressings, and closed space explosion leads to inhalation injury risks. So again, these are all the pearls, pitfalls, and the myths that needs to be we should pay attention to, that these are not the things that are right. So that concludes our topic of emergency treatment of the burns, in which we covered in detail the different types of the burns, depths of the burns, methods to measure the body surface area affected by the burn, and then the treatment and management of the burn patient. Thanks for watching sqadia.com.